Perfect. So tonight, welcome. This is week 7, 7 of 9. So we've got the spine on tap tonight. I think that you all are in for quite the treat. I think if Dr. Guathmy hadn't rigged the survey last time to have Dr. Miller's name auto-populate when it came time to vote for the best lecture, I think that it is distinctly possible that spine as a whole would have won best lecture for part 1, but he rigged it with Dr. Miller, his partner's name, auto-populating, so you had to actively change it off of that. Anyway, we're going to get started with Dr. Scheimer, who is going to introduce the spine division, and then Dr. Singla is going to go over some cervical spine trauma. Alyssa, one of our PGY2s who is currently on the spine service, is going to talk about some spine cases. And then Dr. Hogg, one of the PGY4s who's currently the chief on spine, is going to go over some of the mentorship here at UVA. So Adam, I believe it should be all set up for you, Dr. Scheimer.
I'm here. I'm fully embarrassed that I don't have my preferences to allow me to share my screen. Hold on, everyone. Hi, good evening. Welcome. I'm going to amaze and astound here in 2 seconds once I can figure out my computer.
The green button at the bottom that says share screen is what you're going to do.
I know, and it looks like it's going to work, but it says that
you're good now.
I'm sharing. All right. Can you guys see me?
Yes.
Yep.
Right on. All right, guys. Well, welcome. I want to thank, first of all, you guys for taking time out of your Thursday evening right before the last of the 2 presidential debates starting at 9 p.m. But thank you guys for taking time out of your busy schedule. I'd like to thank Dr. Bachman, Dr. Guathmy, who are our associate and program residency program directors here, and they do a really phenomenal job. But can you guys hear me all right? Okay, good. I got a thumbs up from the Caribbean. So what I'd like to do is introduce the spine division a little bit. As you know, orthopedic comprises a series of subspecialties: pediatric, adult reconstructive trauma, and spine is actually one of the prime foundations of orthopedics. Really, a lot of orthopedics started with addressing spinal deformity in general, but spinal deformity. So I'm just going to start off by introducing a little bit of us. This is the department as a whole. Dr. Guathmy had to run, but Dr. Bachman in his stay introduced kind of the session. Our division head is Frank Shen. He usually gives this talk, but he has some other meetings to be to tonight. We're going to have a brief talk. It's actually going to be on cervical trauma. This is from last time. I adjusted all the slides except this one. We're going to have case presentations with Alyssa and Emmanuel. Ignore those names there. And I don't think we're going to do the Charlottesville life, but we'll have some closing statements at the end.
It'll be mentorship.
Mentorship. Bingo. You can see when you get someone else's slide and just get out of the OR what happens. Don't do this, kids. Do as I say, not as I do. But our faculty, we have 5 full-time spine attendings, 3 physician's assistants, 1 nurse practitioner who works in the inpatient side. As of now, we have 1 spine fellow. We are potentially looking to expand to 2 based on our significant increase in volumes over the past couple years. And that would absolutely not affect the volume that a resident will see, just because we're overwhelmed right now and our PAs are standing in a lot when we actually don't have enough coverage. So it would not be an issue with resident volume. We have a PGY4 and a PGY2, and then on alternating months, so we and neurosurgery alternate spine call by month. So even months, this one we're on, odd months, our neurosurgical colleagues are on. So we have an intern, Liza's on with us this month. And we have 1 full-time spine research fellow, 1 a year. Outpatients done currently at the Spine Center, but we are moving to a brand new big beautiful facility called the Ivy Mountain Project, but it's going to be the orthopedic UVA orthopedic spine center. That'll be a new facility where we do clinic, have our offices, and do some outpatient surgeries. It'll predominantly be sports and joints doing outpatients there, but hopefully we can expand it doing some spine stuff there. Surgery's done in the main hospital predominantly. We do some surgery in the outpatient setting. And Anuj and Dr. Lee and Dr. Hazanzad have expanded some surgery up to a satellite hospital as well. But again, that's not covered by the residents, but important for kind of the overall scope of the division. That was a crazy sound. Why isn't that going? There we go. This is Dr. Shen. This is how it works when you show pictures. Everyone's pictures are much younger than they are now. No one wants to get rid of their initial picture for whenever they come to work. He's the Warren Stamp Endowed Professor. He's our division head. He did fellowship at Rush, residency here, did med school here, undergraduate at Michigan. He's published a ton. He is nationally and internationally renowned for his basic science work in spinal fusion, but also his work on complex spine reconstruction for deformity and tumor. He's got a bunch of funding. He's the course director for the part 1 of the board review, and he is an oral board examiner. And he's also recently the outgoing head of the promotion and tenure committee here at the university. That's not important for you, but really quite a bit of significant involvement, both locally in the university, nationally and internationally. This is me. I'm the medical director up on the floor. I'm the director of the group that decides what implants and devices can come into the university. That's what the scope committee is. I did fellowship at Jefferson, my residency at Pittsburgh, undergraduate and medical schools at the University of Virginia. You'll see a little bit of a recurring theme with the university. I think once it gets its hooks into you, a lot of people like it and tend to stay. I've published some, certainly not as much as my partners, but I do take care of the athletic teams here and up at JMU. And I'm on some board of journals. Dr. Hazanzada, also associate professor, he took over the spine fellowship from me about a year ago. He also has a really robust clinical research program here. He did fellowship at Rush, residency at Hopkins, medical education over at Hamburg in Germany, published a boatload. He has a lot of money in clinical trials. And he's faculty for the part 2 review. Dr. Singler, you're going to hear from later as we go over some cases. Did his fellowship with us, but also at Shriners up in Philadelphia and down at LSU, doing really broad spectrum of spine care from pediatrics through adult. He did his residency at Seth Medical College in India, and has publications as well. He's in the pediatric harm study group with our senior partner, Dr. Abel, and also Dr. Bachman. They generate quite a bit of excellent kind of multi-center collaborative research papers. And he's really has a keen interest not only on complex spine, he does do some pediatric spine work with Dr. Bachman, and he's also trying to develop our minimally invasive and interventional spine section. Dr. Lee is the director of the Basic Science Research Laboratory. He did his fellowship at Columbia with Drs. Lenke, Lehman, and Rue. He did his residency here. He did his medical school at Xi'an Medical University, has published a lot, has really a phenomenal amount of funding and real funding, kind of non-institutional national funding. He is part of the NIH study section, and people who know anything about basic science, that's really an impressive thing to be a part of. His basic science research, and I don't think Alyssa and the residents quite understand, is really top notch and world class. He's really an amazing researcher and a great surgeon, great doctor, great person. These are our PAs. Rosemary Tiger is the most senior of those PAs. She's been with us about 7 years. Sarah just joined us. She was previously a very senior PA in the hand division and went out to Colorado for a while, but she's back now with spine. She's seeing the stark difference between hand surgery care and spine care. And then Megan just joined us about 2 weeks ago. And our nurse practitioner is Deborah up on the floor. And really a fantastic team. And the residents should know as you move forward, certainly the attendings and your other residents are probably the key driver of what you're looking for. But a lot of these kind of mid-level providers or physicians extenders or really the extended staff in general with nurses are really an important part of your experience, because a lot of the kind of the non-educational kind of service stuff they can help out with, and that's a really nice thing. So the resident rotation, like I said, is the second and the fourth year. It's for 10 weeks. First year during spine trauma month. In general, obviously there's some fluidity to this depending on where our volumes are, but in general, you spend 3 days in clinic, have 2 days in the OR. Usually when things aren't crazy, things have been a little bit crazy, but there's a little bit of free time, maybe a half day a week to do some research. That's not programmatically built in, but I do think there's some opportunity. I'm sure Alyssa and Emmanuel say, yeah, sure, right. But it's just been a kind of a crazy month. Second year, the second year, that's a weird way that with Professor Shins, but the second year on Friday takes general orthopedic trauma call. So the residency is built around a night float model. So during the day, the 1206 pager, that's just the pager number, but essentially who takes call is split up amongst the divisions. So on Friday, the second year gets to break free of spine and take general trauma call. The fellow rotates on one of 4 services. It's not really one attending because we have 5 attendings, but it's essentially me, Shen, Hamid, and then Dr. Singla and Lee share the attending for a quarter of the year. That may change. Residents rotate on the other 4. So like right now, Sam, who's our fellow, is with Dr. Hazanzada. So the other residents primarily, there's some overlap, but primarily work with the other 4 of us. We do have a spine cadaver lab, and that's not only just a spine cadaver lab, but really an orthopedic cadaver lab. It's an impressive facility. I know that Dr. Chabra put a lot of effort into making it happen. It's got lead-lined walls. You can bring fluoro in. Industry can come in. You can put implants. Put screws in the bone, put screws in spine, put cages in. So it's pretty neat. Dr. Lee, who's a great educator, spends time every Thursday doing orthopedic in training and board questions. We have an hour long that sometimes is an hour and a half long indications conference. We do that Thursday morning at 7. Which is it's one of my favorite parts of the week, just because it's great to see other people's cases, what they did, and I hope the residents get some education out of it too. What do? We do everything in the spine, really, from the occiput to the sacrum. We take care of degenerative deformity, tumor, trauma, infections. We both do traditional open surgery, but now increasingly some minimally invasive techniques. We do all approaches to all areas of spine, anterior, lateral, posterior. So really kind of the full spectrum of spine care. We do have an interest in developing more interventional stuff. And you'll find increasingly there's a bit of a gray area between MIS and interventional spine care. And interventional spine care, what we're trying not to have happen is be like the cardiothoracic surgeons who said they didn't want to do cardiac caths and angioplasty and have that pass us by. So we're all trying to have a little bit of interest in some of these things seen below. We have really the full gamut of enabling technologies, and as you guys go through, you'll kind of learn what this means. It's a new concept, but it's not only 3-dimensional intraoperative imaging, but also mating navigation to that. So the idea that you can take an intraoperative CT scan and then send it to a computer and have each one of your instruments registered to that new world. So it's kind of like you're doing spine surgery, orthopedic surgery, like you drive a Tesla. I mean, it doesn't do it quite that nicely, but it really, and you can see this picture on the bottom left where your screw or your screw trajectory is going into the subaxial cervical spine, which is previously a pretty hard screw to put in. But it allows us to do some pretty neat stuff that we had trouble with before. And then kind of the other side of enabling technologies is robotic assistant, which is at least what we use through the Mazor system, which is a pretty mature robotic system. And then there's some new augmented reality stuff coming down the pike where you potentially wear goggles or have a screen in front of you where you have like a real-time visualization of the 3D anatomy of the spine. But this could also be pelvic work. So just so you guys know, it's a pretty neat time to be in orthopedics. Oh geez, that's crazy. I didn't even know that was there. So coming down the road, there you go, augmented spine surgery and integrated systems. This is just showing a couple of cases we do. I think they put it together. So we're not going over this case. I think Professor Shen put this to show off a little bit, but 21-year-old, and you can see she's got a pretty high grade spondylolisthesis, probably a grade 2 or 3 down there. And oh boy, never mind.
That's the presentation from last time.
This is before. Okay, I didn't know if he had put these in here. Well, perfect. I think I'm going to hand it over now to Dr. Singla, and please, you guys should all feel free if you have any questions. And I think Dr. Bachman, Dr. Rothman feel the same way about our program, how things are set up, compare and contrast. I don't know if I can do that quite as well as I could have 5 or 10 years ago to other programs, but I think it's really good to kind of get an idea of what you're looking for. And then I will also say that we have a stable division and really a stable department, right? I mean, this is what I tell people looking for residency too, is you don't want a department that like the chairman's leaving and things are falling apart. And really, we haven't had anyone leave in, I don't know, 10 years, kind of crazy. That's not true. Dr. Carson left to take over the head of another department. But other than that, we haven't had anyone leave. So it's a great place to work. I think it's a really good place to train. That's my little mini sales pitch. Now I'll hand it over to Dr. Singla.
Thanks, Dr. Scheimer. Okay, well, that doesn't look right.
Yep, that's the cervical spine trauma. All right, my name is Anuj Singla. Thanks everybody for being here. We'll be talking about cervical spinal trauma briefly. Obviously, it's a very broad topic, but we will try to cover some of the important and the usually discussed points of cervical spine trauma in this brief talk. Cervical spine trauma is a very common but potentially devastating injury. It happens very commonly with the bimodal pattern. In the elderly, it is usually a low energy trauma like a ground level fall, but in the younger patient, more active population, it can happen with the high energy trauma. Motor vehicle accidents are very common causes of that. And the motor vehicle accidents are pretty common, like everybody knows. There are about 6 million car accidents in US every year. That comes down to about 16,000 accidents per day. The other common causes for cervical spinal trauma include falls, gunshot injuries, and the sporting injuries, diving injuries. These should be suspected in anyone who has a high energy trauma or a head injury or a neurological deficit. These injuries tend to happen in association with other injuries very commonly. About 50% of these patients will have some kind of visceral or skeletal injury and about 20% chance of having another fracture in the spine somewhere else. Looking at the spine from the side, we have the vertebral bodies on the front side with the intervertebral disc in between. On the back side, we have the spinous process, laminae, and the joints. Looking at the vertebral spine structure from the front, vertebral bodies in the center and interposing disc in between the two vertebral bodies, and an anterior longitudinal ligament runs on the front side of the vertebral body as a continuous piece. This is the axial section or a cut section to a spine where you have the vertebral body on the front side, anterior aspect. Behind that is a space for the spinal canal. Spinal canal is occupied by the dura, the spinal cord, which is protected very extensively on the sides by the pedicles, posteriorly on the back side by the lamina and the spinous process. From the spinal cord comes out a spinal nerve root at every single level on either side, left side and the right side, which passes through the neural foramen. That is very typical for, it's not typical for the cervical level only, and lumbar and thoracic also have the similar structure. The typical structure for the cervical spine would be the presence of a foramen transversorium, where the vertebral artery passes, and the uncovertebral joints. Uncovertebral joints are the lateral projections of the vertebral bodies, and they are oriented about 30 to 45 degrees. And the presence of vertebral artery is also a very typical feature for, unique feature for the cervical spine as compared to the thoracic and the lumbar spine. Vertebral artery originates from the subclavian artery. It enters the spine commonly at C6 level, sometime at C7 level, runs through the foramen transversorium, and comes out of C2 body, goes out laterally, and then runs on top of C1 arch before it goes to the foramen magnum and making basilar artery. So presence of vertebral artery puts cervical spine into some challenging situation, as we cannot access the spine from the lateral position as we can do for the thoracic and the lumbar spine. Also, the vertebral artery is at risk for injury along with the other structures in the cervical spine. In terms of anatomy for the spinal cord or the neural structure, spinal cord diameter is about 8 to 9 millimeters, and it occupies about 50% space for the canal. And the neural foramen contains the nerve root, which has pedicles above and below. It has the facets on the backside and has a disc or body and uncinate process on the anterior side. With the cervical spine trauma, all the structures in the neck are at risk, including the bony structure, vertebral body, pedicle, lamina, spinous process, ligaments, tendons, and which can cause a dislocation or subluxation of the vertebrae, or it can also lead to the associated injury to the disc herniation and disc rupture. The most important question to be asked for a cervical spine trauma patient is in terms of a neurological stability or mechanical stability. Neurological stability refers to the status of the spinal cord. Is the patient has a spinal cord injury, and if that is complete or incomplete. Complete spinal cord injury would mean loss of all function, motor function, sensory function, including bladder and bowel function below the level of injury. These are pretty devastating injuries, and the recovery is, the chances of recovery are low, very low with the complete spinal cord injury. The incomplete spinal cord injury is when you have preservation of some function, motor function or sensory function, bowel bladder function, mostly the sensory function around the perineal region. That would classify the spinal cord injury as the incomplete injury, and those injuries have a better prognosis, and those need to be picked up as earlier surgery decompression gives a chance of a better recovery for these patients. The other aspect is the mechanical stability. Is the patient having gross instability of the spine that needs to be addressed or protected? Or if there is subtle instability at the first instance, when you have the CT scan or the MRI, which could become potentially unstable when the patient bears load or when the patient is sitting or standing. So that needs to be identified and defined. In terms of instability, there are various criteria. The most commonly used criteria for cervical instability is White and Punjabi's method, where we look at the angulation between the vertebral bodies. Angulation more than 11 degrees between adjacent segment is evidence of instability, or translation of the body is more than 3.5 millimeter, facet joint widening, spinous process widening, malalignment or rotation of the facets along with the lateral tilting. All these factors need to be picked up on the imaging to define instability of the spine. Various classification system for cervical spine injury to look for conservative versus surgical management. SLIC classification or subaxial cervical spine injury classification looks at different parameters for the injury, including morphology or how the fracture is for the vertebral bony structure, involvement of the ligamentous complex, especially posterior ligamentous complex and the intervertebral disc status, and evidence of any neurological involvement. So based on this classification, we have different scoring system, and presence of score of 4 or more is indication for surgical intervention or spinal stabilization. 3 or less is conservative management, and 4 is kind of indeterminate. It could go either way. The other classification system commonly used is AO classification system, which defines the spinal injury based on the fracture morphology or mechanism of injury, compression fractures, tension band fractures, translation injuries, or the facet joint injuries. Evaluation of the cervical spine injury or the instability, looking at the lateral radiographs. Lateral radiographs provide extremely valuable information. So when we look at the lateral radiograph of the spine, you can artificially draw 4 lines, one going from the anterior aspect of the vertebral bodies, one going at the posterior aspect of the vertebral bodies, one going through the spinal laminar line, and one going at the tip of the transverse processes. Usually, in common scenario, these lines should be fairly smooth running line in a nice curvy manner, and any major shift, any major step off should should give you suspicion for any spinal instability or dislocation. Beyond this, the lines, you can also look at the soft tissue structure for the retropharyngeal abscess. On the antero posterior or AP view, you can look at the vertebral body height, comparison to the adjacent level above and below, height of the vertebral disc space, alignment of the transverse processes, and the alignment of the spinous process. Alignment of the spinous process is crucial because that can give you a subtle hint about the spinal dislocation or instability. So any obvious instability, you can look at the spine, looking at the overall alignment, see if there is any major step off, but also in presence of any soft tissue widening can be suspicious for any major hematoma from the trauma or infection or abscess formation. Open mouth odontoid view is valuable for the upper cervical level evaluation at C2 dense and C1, C2 articulation. Various lines and distances have been defined, which is we're not going into detail for that for the cervical spine imaging assessment. CT scan is crucial. CT scan is the basic for cervical spine evaluation or any spinal evaluation, as it provides excellent clarity for the bony shape, any fracture lines that can be clearly seen on the CT scan, and it is crucial for trauma evaluation. It's a very quick evaluation, and the spine can be screened within a few minutes for presence of any bony injury, or as well as suspicion for any major hematoma or ligamentous injury. MRI has extreme value in neurological injury to see for any spinal cord injury, presence of any significant stenosis, ligamentous injury, and hematoma around the spine. Talking about the individual trauma pattern fractures, I'll start at the top. We'll start with the occipital condyle, which can have 3 types of fracture: type 1, type 2, and type 3. Type 1 is the impaction fracture. Type 2 is extension of the basilar skull fracture, and type 3 is the alar ligamental fracture. Most of these injuries are stable and treated without surgery with the cervical collar or halo vest application. Some of the ligamentous injury can be unstable and may require a rigid vest or a halo vest application, but uncommon for them to require a surgical. Atlanto-occipital dislocation is the widening of the atlanto-occipital joint more than 5 millimeter, and presence of any prevertebral swelling with that. It's usually a very fatal and significant injury. Patients are apneic at the scene. Uncommon injury, but little more commoner in the pediatric patient. These are potentially very unstable injuries and usually require immediate stabilization and operative management to ensure stability of the spine. Uncommon to have less than 2 millimeters of osteoligamentous injury on traction test, which may warrant for non-surgical intervention, but usually they are pretty profound ligamentous injury and require surgical stabilization, mostly extending from occiput to C2 level. Coming down to C1 or atlas, they can have a fracture on the anterior arc, posterior arc, and commonly a Jefferson fracture. This is a pretty wide area for the spinal cord, and neurological injury is generally rare unless associated with significant instability. Anterior and the posterior arch fracture usually do not require surgical intervention. Jefferson fracture is the compression fracture of the bony ring of C1, which is usually associated with a lateral mass splitting and rupture of the transverse ligament. Bony injuries will heal conservatively without any intervention, but the ligamentous injury will not heal on its own. So if there is any presence of ligamentous injury, that may warrant surgical intervention, or the spine may be unstable. So transverse ligamentous rupture can be seen with anterior atlanto-dense interval more than 5 millimeter, or look at the overhang for on the open mouth odontoid view, overhang of the lateral mass of C1 beyond C2 vertebral body on both sides. Distance combined A plus B more than 7 millimeter, or at anterior ADI distance more than 5 millimeter. That's evidence of a transverse aerial ligament disruption and may require surgical stabilization. Axis C2 is the most commonly involved vertebral body in the upper cervical region. Odontoid fracture, dense fracture, these are the most common fractures. It accounts for nearly 2/3 of all C2 fractures and about 10 to 20% of all cervical spine fracture. Common injury with a bimodal pattern as with other cervical spine injuries. Anderson and D. Alonso classification for odontoid fracture type 1, 2, and 3. Type 1 through the tip of odontoid, type 2 at the base, which is the most common, and type 3 through the body of atlas. Most of the time, type 1 and type 3 can be treated with the conservative management. Some type 3 requires surgical intervention. Type 2 is the most common and most controversial. It has a very high rate of non-union and high rate of displacement. Non-union because of it's a small area of bony contact, as well as the watershed supply, blood supply zone through the waist. It happens very commonly in the elderly population, and which are very high risk group for non-union. In the younger population, it can be associated with major displacement. Treatment is very controversial, including immobilization versus surgical intervention. There are studies favoring either aspect of the treatment, conservative versus surgical. In fact, there is a multi-center study going on right now to see which treatment offers better outcome. And Dr. Scheimer here is leading that trial part for UVA spine group. Hangman's fracture, another very common fracture happening at C2 level. This is the traumatic spondylolisthesis. It's a type 1, type 1A, type 2, type 2A and 3 variant. Type 3 is uncommon, which is associated with disruption of a C2-3 joint along with the traumatic spondylolisthesis. Type 1 and type 2 is in terms of the displacement and the presence of any injury to the other vertebral body, C2 vertebral body part, as well as the disc. Most of the time, these injuries are very unstable and require surgical intervention. Surgical intervention could be anterior or posterior for these injuries. Anterior injuries would anterior instrumentation with ACDF, or posterior instrumentation with a direct repair or C2-3 fusion. For the subaxial spine, common injury patterns are flexion. With the flexion or hyperflexion injuries, you can expect bony impaction on the anterior side, as well as posterior stretch or distraction on the ligamentous or the bony structures, which can lead to the vertebral body's wedge compression fracture, hyperflexion sprain through the ligamentous complex, bilateral interfacetal dislocation, or teardrop fracture. So depending on the area involved and depending on the magnitude of the hyperflexion injury, different fracture patterns are seen. PLC, or the posterior ligamentous complex integrity, is very important, as that will define if the a patient has mechanical instability. Sorry. So that is something we need to look at for any suspicious unstable fracture. We need to get an MRI to look for the posterior ligamentous complex integrity. Wedge compression fractures are common fracture. Usually these are very stable unless it's associated with posterior ligamentous complex, which can render significant instability and require surgical intervention. Flexion teardrop fractures are present with a severe hyperflexion. It involves disruption of all columns and usually presents with a severe neurological involvement, especially anterior cord syndrome. Anterior cord syndrome is an incomplete spinal cord injury pattern. One of the worst prognosis, incomplete spinal cord pattern because of the ischemia through the anterior spine. We'll skip this part. All right, bilateral interfacetal dislocation or the locked facet is a very common injury. These are called locked facet, but these are very unstable injuries. And you can imagine the spine is kind of going into hyperflexion, and both the facets, they have equal flexion strain, hyperflexion, and the facets start to subluxate bilaterally. So imagine the facet from here will start to jump and go all the way to the front side and gets locked there. It is locked in the sense that it will not reduce on its own, but it is unstable in the sense there is a significant translation. Commonly seen more than 50° of vertebral body translation with these injuries, and they have very high rate of neurological injuries associated with them. Hyperflexion teardrop fracture dislocation. These are significant injuries in the vertebral body with hyperflexion, with displacement and dislocation at the vertebral body. Significant neurological injury, almost 100% chance of a major spinal cord injury with them. I'm going to skip these subtle fractures. Flexion rotation is another common pattern. All right, back. Flexion rotation is another common pattern for the cervical spinal injuries, where there is the flexion of the spine associated with some rotatory component to the force. And the important injury pattern to be recognized is UID or unilateral. Ooh, something major, man. Sorry, guys. We're getting a lot of alerts. Unilateral interfacetal dislocation or the fracture dislocation. Compared to the bilateral facet dislocation, the distinction is important as there is component of flexion and rotation. The forces leading to this injury are more profound towards one side. So that leads to unilateral facet dislocation. As the fracture starts to rotate, as the facet starts to rotate, it gets locked, but the subluxation would be less as compared to the bilateral. So usually less than 25% or 1/3, 1/4 of the vertebral body compared to the bilateral, which is usually more than half of the vertebral body. A little less neurological involvement because the amount of translation is less compared to the bilateral, but a very common injury pattern. Look at the spinous alignment in the axial and the lateral, in the lateral and the frontal view to pick up for any spinous process malalignment. On the CT scan, you can pick up the facet joint orientation. This is the normal facet, which looks like a hamburger. But when you have the dislocation, it looks inverted. It's like the buns are inverted for the facet dislocation. Involvement of the facet joint or the ligamentous complex defines how if you can expect instability or if the patient can be managed conservatively. For a facet fracture, involvement of the fragment more than 1 centimeter or more than 40% of the lateral mass involvement is considered a sign of instability. Look at the major ligamentous injury on the MRI. Posterior injury is a little less common than anterior and a little less involved spine in terms of the posterior arch fracture, which can usually be managed with a conservative treatment, including at the base of the spinous process or through the lamina or through the pedicle, unless major ligamentous complex injury is involved. Extension fracture dislocation is a common, not a very common pattern, but commonly seen for ankylosed spine or the fused spine, where the spine hyperextends and can have major translation or instability, and very high risk of a neurological injury and epidural hematoma associated with these injuries. Usually require surgical intervention, especially in the ankylosing spine. Burst fracture is a unique injury, as very easy to pick up on the CT scan. You can see a clear-cut line through the through the vertebral body extending all the way to the posterior aspect. Usually these are very high energy injuries with major neurological component and may require surgical intervention.
All right. Do we have a case?
I have a case if you want me to go through it.
Yeah.
Jump to the case. Otherwise, I think Dr. Singla, if you all remember everything that he just presented, you are going to get 100% of your OIT questions correct about cervical spine trauma.
That's
Very,
the basic
very,
for
very,
spine rotation.
very thorough. But I think what it gives you is a sense of how broad of a injury patterns can occur from a spine standpoint. And so it really helps. I think one of the best things, one of the best pieces of advice that any program director can give you is to really anchor your learning on cases. So let's do a case, Alyssa, and then let's leave some time for Emmanuel to get us to talk about mentorship. All right, take it away, Alyssa.
So this case is kind of designed to be interactive, but I know that we have a limited amount of time, so we can skip through it kind of quickly. So the first one, this was actually one of Dr. Shen's patients a few years ago. It's a 55-year-old guy. He presents with neck pain after a snowboarding accident. He fell down, hit his head on a tree, and he reportedly was able to ambulate afterwards. So you don't hear about this until you get a page around 11 o'clock at night that says alpha trauma, snowboarding accident, please evaluate. So that's about all the information you have. What's kind of your next step that you would think about doing?
Bueller.
I can keep talking. That's okay.
Take
So
a look at
the next-
X-rays.
X-rays.
Yeah.
Okay, there you go.
That's a good start. I think one of those, it's kind of a guess what I'm thinking situation, but I think one of the first things that you want to do, and somebody mentioned C-collar, it's another great idea, is getting an exam. So examining these patients is probably first and foremost, especially before you're calling attendings at my level, is that you've examined the patient. So this guy is tendon palpation, C and T spine. He doesn't have any palpable step-offs, no deformities of the cervical, thoracic, or lumbar spine. He's laying flat. So usually when you go see these patients in the ED, especially in RED, they do a really good job about keeping them flat and keeping them in a C collar before the spine team comes and evaluates them. And then it's kind of on you to decide, do you raise their head of bed one, or do you take the C collar off, or just kind of leave them as is? So he's moving all of his upper and lower extremities. He does have 1 or 2 beats of clonus, bilateral lower extremities. But other than that, he's fairly neuro intact. What are you thinking next? And this goes to James's comment about imaging. So X-rays, and then what else? What other kind of imaging would you want?
CT.
Perfect. So thankfully, these people come to the ED and they have a pan scan of their whole body. And when you're looking at CT scan, and I think this is a skill that I'm still developing, and it takes time to learn, is to how to kind of intentionally look through a CT scan. And so I put 3 cuts here. The top one is kind of a mid-sagittal cut. You have a sagittal, and then you have an axial on the right. And then you have an off-axis on the right, and then off-axis on the left. So if you do that pretty quickly and routinely on all these CT scans, you can at least get a gross overview about overall alignment, and then just kind of all off-axis, the neuroforamen, and just kind of the shingling that you're looking for at each level. So is there anything on the CT scan that you can see that looks a little abnormal, particularly in the mid-sagittal? Maybe that'd be the first one that you'd be able to see some sort of abnormalities of a vertebral body. So kind of looking down, you can always start at C2. This is going to be your first vertebral body that you can usually count down from pretty easily. So this will be 2, and then 3, 4, 5, 6, 7. So I would say that C7 looks a little abnormal compared to the rest. The rest look like rectangles, and C7 is looking a little compressed. So that's something you may want to look a little more closely at. And my cursor was aimed on showing that it was central, left, and right, but things you can also see. So this is actually at the C7 level. So this is showing you an axial cut of the C7 vertebral body, and that gives you an indication about which off axis you are on either side. And is there a type of fracture based on Dr. Single's lecture that you may think of that this would be? Either kind of a compression mechanism, a burst fracture? Does it give you any sort of idea of what type of fracture it may be? So I'd say you're probably in a burst fracture kind of general area. And just like Dr. Single was talking about, the importance of an MRI in a lot of these patients. So we get MRIs for a few different reasons. So just at a very basic level, you get an MRI to kind of evaluate the soft tissue structures. And secondarily, you get to evaluate the posterior ligamentous complex. So those are two things that right off the bat, you can use an MRI for in the trauma setting. And lastly, an epidural hematoma is something that you can look at because that'll change your management. All three of those may. So
yeah, a couple of responses, at least a couple of guys who mentioned a burst fracture, which is right. Look at the CT scan and the axial section. You can see the fracture line extending anterior to posterior to the vertebral body with major disruption and subluxation of the fragment in the canal. That's perfect.
And then on the MRI, I just kind of wanted to make note of different MRI sequences. So I think that's one thing that I didn't quite understand as a med student is when to look at a T1 versus T2 versus T2 stir and kind of the benefit of each one of them. I would say in spine imaging, you're commonly looking at the C2 to evaluate the soft tissue structures, and then also, or the T2, and then the T2 stir can kind of tell you, with a lot of older patients who come in with spine trauma, many of them may have old compression fractures, anterior inferior wedging. And so it can kind of give you some sort of hint of, is something acute versus chronic? So that's what you can use your T2 stir for. So now what? We talked about diagnosis of the C7 burst fracture, PLL involvement based on the MRI. So would you want to do non-operative management? That's always an option for any patient, really. Or would you like to operate on this person? I think that's kind of your first question. All right, Mary says operate. Amazing. We'll go with Mary's answer.
Take Mary. I like how she rolls. That's a good orthopedic answer.
Mary just wants to operate. So
No, I mean, this is a little bit. It's gotten late, and I think this is an interesting one. I think that probably this was chosen by Alyssa because people will argue one way or the other. I think that with a cervical burst fracture, certainly you worry about both mechanical and potential impending neurologic instability. But then as you kind of think to the next level, you want to look at the posterior supporting structures. You want to look at kyphosis, whether they have any pre-existing, acquired stenosis or spinal cord compression. So I don't know. This one I may try to treat closed. I might put them in a CTO. Maybe I'm crazy. If I'd look at it a little bit more, I would change my mind, but I may treat this closed. I would imagine we're not presenting a closed treatment of fracture, so it's probably going to be some vertebrectomy infusion. Maybe Alyssa can tell me differently.
no, but now you guys can get some insight into spine conference on Thursday mornings. In all honesty, it is interesting as a resident to kind of hear an attending level conversation about operative versus non-operative management. And so Dr. Shen decided operative management. And so I went through kind of a quick, since a lot of you guys probably haven't been in spine cases, just kind of the overall, what does it entail? So this is in the operating room. You localize the level of the fracture that you want to operate on. You'll make your incision. So just kind of orient you. The head would be to the left, the feet to the right, and then medial and lateral. For an anterior approach to the spine, to the cervical spine, that's about the size of your incision. You'd go through skin, subq, through platysma, and then you can identify underneath there the pretracheal fascia. You'd pull the vagus nerve or you don't want to see the vagus nerve, but you would pull the carotid artery laterally with the sternocleidomastoid. And then below that, you'll see the prevertebral fascia, the longest coli muscle. And here, actually, Dr. Shen did placed a fibular strut graft. So you can kind of see that in this image to the right. That's actually a fibular strut graft there. And then place the anterior cervical plate after that. So it ended up being a C6 to T1 anterior cervical fibular strut with anterior cervical plate. And unfortunately, I know we went through that a little quickly, but I know we need to kind of move on. So if you guys have any questions about spine, Dr. Scheimer and Dr. Singla would love to answer your questions. No, I'm kidding. Emmanuel and I are both on service, and we've actually had a really good experience. So if you guys have any questions about spine from a resident perspective, please feel free to reach out to us. And then Emmanuel will go on about mentorship.
Yeah, Emmanuel, let's fire that up so we can try to stay. I know everybody wants to get to the debate.
Sounds good. All right. Can everybody hear me okay?
You sound great.
Perfect. I'm Emmanuel. I'm one of the fourth year residents here at UVA. Currently, like Alyssa said, on spine with her. Thank you very much, Dr. Bachman, for being here tonight, and Dr. Singla for your great presentation, as well as the great introduction, Dr. Scheimer. When you start your residency, it can be very intimidating. You've been on a long regimented path, and then all of a sudden you're dropped into residency at a new program in a new town, new responsibilities. So all of this can be pretty overwhelming. So it's incredibly important to have some sort of guidance, I mean, as you've had through undergrad probably and medical school, it becomes even more important in a residency. And it's always kind of a weird situation where you're not quite sure how to find a mentor or how to really know if this mentor is right for you or not. And so here at UVA, it is kind of made easy by you being set up with a mentor from the get-go. And your mentors, they can have multiple shapes and forms. You can have them for personal growth, for development, for support, work-life balance kind of questions, because it's good to have somebody who went through your situation before and who has all this experience. But then again, in terms of professional development, once you're a resident or once you're a physician and you're about to be a surgeon, there are so many different career paths and choices and things that you need to learn and know about, whether it's, going into academic or private medicine, whether it's regarding research, or even the industry aspect in terms of consulting, product development, politics, organizational involvement. All of this is kind of a different ball game once you enter residency. So here at UVA, as an intern, you're being matched with, or you get assigned a PGY4 resident. So from day one, so to speak, and even before that, even before you move, you have a contact or somebody who can talk you through the move, through the different things, how to get settled, where to get maybe a person who can fix your plumbing if you bought a house and things are not working, or just simple things like that. But then also the rotations, right? Because all of a sudden you're the intern on trauma and you have all these responsibilities, you have all these questions, and you're the one that gets asked the most questions. And so it's really important to have somebody who's been there, who's done that, and who can give you some advice on that. In addition to having a upper level resident, you will also have a faculty mentor. Dr. Hasan Sada was assigned to me. I don't know if it's because we're both German, but it ended up working really well. You get 2 meetings a year usually. I mean, it's not very formal. Some people like to meet for a coffee break. I know Matt used to meet for play dates with Dr. Bachman because they had kids in the same age group. So it's very easygoing. It's not forced. It's just, having somebody who can talk to you, who can ask you about your interests, how are things going, and kind of take you out of that daily grind and really, give you some thoughts and perspective. They're also great for research resources, or if you're not quite sure yet what kind of a fellowship, or if you want to do a fellowship, they can kind of direct you. And our program is set up that we have research grant rounds where you can rotate around and kind of find different fields and just experience. If you're not sure what you want to do, you can go into the sports research program or the spine or whatever it may be. And that might give you some more insight in terms of what you might end up wanting to do. Which brings me to the next part here. Aside from mentorship, the fellowship process, that's also another thing that's always on your mind when you're an intern or a resident in general. You're like, now I'm an orthopedic resident, what's next? Everybody has kind of a different approach. There are some people who come in and they already know what they want to do. There's some people that don't know until their 4th year. And we really have a lot of support from every staff, from every rotation, from every different division. It doesn't matter who you ask, you'll always have an honest answer, and you'll always get the support you need, whether it's networking, letters of recommendation, really everything that you can possibly think of. Our attendings here are very well connected. I remember when I started my spine rotation, I'm in the process right now with fellowship application. I talked to Dr. Scheimer, and he's well connected. So he sent a text, which I really appreciate. So yeah, things are really, those little things really make a big difference when you're trying to apply for fellowship and try to set up your career. Fellowships, some people don't know if they want to do a fellowship or not. Nowadays, majority of people are doing a fellowship. Some of it has to do just with the marketing aspect. There are a lot of hospital systems that won't even hire a non-fellowship trained physician or surgeon just because it's if you can market somebody who's specialized in total joints or sports or spine, it's just a lot more marketable. But then also everything is becoming more and more of a niche practice these days. So it's almost guaranteed. Majority of people who come to UVA usually end up doing a fellowship. And then other than that, for me personally, I always knew that I kind of wanted to do joints. I toyed around with a lot of ideas throughout my residency. I really enjoyed all of the rotations I did. So I had a little bit of hard time then to commit. But we have a fantastic match history here at UVA. Whether it is prestige that you're going for, or whether it's just the location that you want to end up. We have had really great, fantastic match results over the last decades, and Dr. Charver plays an integral role. He supports anybody, no matter what fellowship they want to go into, and anybody here really is behind those residents, and it feels good to have that support. That's pretty much it from my part. I want to keep it short here, and I want to have some more time for questions if the viewers have any questions.
Yes, sir. From my perspective, the reason why the mentorship program was established here was twofold. One, because I felt like, it's easy when you're an upper level to know the attendings pretty well and to kind of know who you need to approach. But when you're coming in, you really are just pretty green. You don't know the area. You don't really know anything what you want to do. And having somebody you can go to have that kind of guidance, I think is really helpful. And then two, I also try to establish a mentorship actually within the residency itself with a PGY4 when you come in, so that when you're an intern, you'll have somebody who is an upper level who you can go to. And then when you're a PGY2, which ends up being a pretty tough year for a lot of people, you have a chief resident who's going to be kind of your go-to person. So if it gets really dark and you get in the weeds or something like that, you have somebody who's kind of assigned to you. And what tends to happen is over the course of your residency, it becomes organic, and you tend to sort of gravitate toward the folks in the specialty in which you're interested. So for Emmanuel being a joint replacement, having interest in that, he sort of gravitates to them. The people who want to do sports, come towards me and Dr. Miller and Dr. Dina and Brockmeyer, and those folks who want to do peds, approach, Bachman and Ramnus and Abel. But I think as a faculty goes, we all are pretty supportive of whatever you guys want to do. It was to make sure we give you the resources you need to become successful. So I think our fellowship match speaks for itself. And the great thing about being a program director is each of these programs that you guys are going to from residency, they almost reach out to us and ask, like, who's coming from UVA this year? Let us know who's going to be the next great thing from UVA. And so you'll see these little pipelines we've established, these different fellowships based on how well our residents end up doing at those places. So great job, Emmanuel. I really appreciate you doing that for us. And Emmanuel is currently in the fellowship match situation right now. So fingers crossed, applications are out. Have you started getting interview offers yet? Does it come back?
Not quite yet. I don't think it's time yet.
Yeah, it's
I hope.
I know all the applications for residency just came in yesterday, and it was a big chunk. So we all got to sift through all those things. Okay. All right, Keith. Sorry, I didn't mean to take in your time, but I just wanted to put my 2 cents in on that. To me, and I know to Dr. Bachman, mentorship and guidance is so important. You know, we can give you all the resources to become smart in orthopedics, but to have career guidance and to have mentorship as far as it's tough. Becoming an orthopedic surgeon is tough. And so we want to make sure you don't feel like you're all alone in this process. And that's a big important thing here at UVA. All right, Keith.
Helping with life stuff.
Yeah.
In general. All right. Well, very good. I want to thank the spine faculty. Dr. Hassanzada, I saw hiding down there somewhere. Hamid, if you're still on, you want to turn your camera on, say hi so everybody knows your face? He may be hiding somewhere, chasing his 2 children around somewhere.
I'm under the impression there were some late spine call cases that went tonight. Josh Lee got stuck in one. So that's the beauty of spine.
There's been late spine call cases all weekend into this week. It's been nuts.
It's rare that I get like an acute ACL, like, oh my God, call Guathman. We have an ACL tear. We got to get him at 2 o'clock in the morning. So
that doesn't exist. That's not a thing.
That's where mentorship comes in. Okay.
All right. Well, very good. Thank you very much to the spine division. Who's next week?
Hand. Bobby Chabra, I would suggest you guys.
Dr. Chabra, the boss
Tommy John
himself, will be finishing it off as far as the divisions themselves. And then we have one more week that we have the residents as a general sort of get together, probably, you know, trying to fill in those late nights on call where you finally get the real truth about the program out of the resident. So try to simulate that. Dr. Guathman and I just start the night and then go hide in a room by ourselves on Zoom while you all talk to the residents. So, and yeah, exactly. And so we'll have that. And then Dr. Guathman and I are still, he's going to hang out with his family. I've got some talks with folks tonight. Dr. Guathman's got some more next week. And then we'll get this thing wrapped up and hopefully we gave you a good sense. Okay. If there's any questions, y'all know how to get a hold of us, but I think we'll call it there. Okay.
Thanks, Keith. Thanks, Winston.
Good night, everybody. Thank you, Dr. Singla.